CT.
Yes, we do.
Perfect. All right, this I think is just a nice example of, I think, a classic thing that trips people up that I've seen happen not that infrequently, unfortunately. This was a patient who has a history of cancer, is undergoing treatment, and came into an outside institution with shortness of breath and hemoptysis. And so I think, as is common in the emergency room, got a PE-CT, right? We can see quite a bit of contrast on the right side of the heart and in the main pulmonary artery. And obviously, right, the contrast is not equal on both sides. There is definitely lower density here. But it still is a little bit weird for a large clot, right? It's a little bit ill-defined. There's some wispiness to it. And if we actually measure the Hounsfield units, even sort of in the middle of it, right, it's 100, somewhere like 90 to 100, or in this case, 112 at this level. So still pretty high for a clot. This, unfortunately, was called as a large pulmonary embolism at the outside institution. The patient was put on anticoagulation and then again started coughing up even more blood, and eventually came to our institution where we repeated the scan. And as you can see, right, we do a slightly different phase. Ours is a little bit later, right? You can see some more contrast on the left side of the heart. And there's still this discrepancy, but again, right, it's not clearly a clot. So this is all just sort of mixing artifact and smoke in the pulmonary artery rather than a true thrombus. And it's probably due to this very large consolidation here that's causing slowed flow of blood in that part of the lung as opposed to the other side of the lung, which is relatively clear.
And it's interesting, there's also an inflow artifact in the pulmonary vein on that side too.
Yes.
Because, yeah.
Absolutely.
So unopacified blood is just still lingering on that side.
Mm-hmm. Yeah. So anyways, cool. Just a nice example of not APE. This next one, this one I thought was just a cute radiograph, or something that I feel like I probably haven't seen that often on a radiograph, despite seeing it on CTs a fair amount. So on this image, obviously, we've got a lot of coarse reticulation, particularly down at the lung bases, at the peripheries, some up at the apices with some areas that look like sort of dilated bronchiectatic airways. And then we also have this thing here, right? This rounded density with like this rim of air around it. So this is, in fact, a mycetoma in this patient who has bad fibrotic interstitial lung disease from, I believe, scleroderma, connective tissue disease. And they have this little mycetoma that's hanging out in their fibrotic lung cavity up here at the apex. But it's just a nice comparison on the radiograph here where you can still see that like nice rim of air around it.
So
yeah.
So there's a big debate around here about what to call this.
Oh, yeah.
So you want to get into this air crescent sign?
I agree. I honestly don't use either of those terms because I agree. I think it's like so confusing. I just tend to be descriptive, but this was a known mycetoma. They've like been trying to treat it. So I probably would have just said mycetoma, honestly.
Yeah. The original description was Monod's sign, but I think the more important thing is they follow gravity. So if you look on the radiograph, the air is on top and on the side, and on the CT, the air is anterior and laterally. And that's the important thing, is they're mobile, unlike like just dangling lung or something.
Totally.
Frankly, I think it's really important to use that term, the Moten sign for this rather than air crescent sign, and reserve air crescent for the cavitation that goes with invasive fungal disease, because clinically, this is so different from invasive fungal disease. You don't want to mix those up in people's minds. So I think that, using a different terminology for this, not calling this air crescent sign, reserving that for invasive fungus, is actually helpful clinically.
Makes sense.
But evidently, according to the latest Fleischner guidelines, they're calling this air crescent sign now. They've given up. And I think that's an important distinction that is therefore being lost. I'm going to resist.
Yeah, agreed. Makes sense. All right, and then my last case, this was one that was, I don't know, maybe somewhat surprising. This was a CT that was done for a patient with a history of weight loss, night sweats, and low-grade fever for 4 weeks. And I feel like we, get CTs for these occasionally, and they're sort of hunting for a cause. And realistically, I think a lot of them end up, at least in my experience, being negative, at least the chest portion. Sometimes they find something in the abdomen. But this one actually had some findings. So as I scroll down, you'll notice that there's a little bit of thickening around the aorta. It's kind of bright. Looks like it may be enhancing a little bit. There's a rim all the way around the vessel. As I come down, the patient does have some areas a little bit more obvious down here in the abdomen where they have some atherosclerosis, but this rim of slightly brighter stuff seems to be almost outside of that. And it's pretty uniform and circumferential all the way around the aorta here. And then if we come back up to the arch vessels, you can see that there's some of that around the arch vessels as well, like our left subclavian over here, brachiocephalic. And as we come out towards the upper extremities, you can still see that rim of enhancement all the way along the subclavian on both sides. So, I was reading this and I said this was suspicious for a large vessel vasculitis. This patient, I believe, is 68 or so years old. And so they ended up doing a temporal artery biopsy, and this turned out to be giant cell arteritis. So we
Wow.
actually found a cause of their symptoms.
That is a really nice case.
Yeah.
Yeah.
Usually it's not, I mean, the ones I've seen are usually more limited. Yours it's just like the whole
Right.
aorta, the
It's
branch
everywhere.
vessels.
Yeah. We
Yeah.
also have the actual full abdomen, which I think honestly shows it really well too. Like all the way down.
Yeah, look at that.
Stops at the iliac.
Right to the bifurcation. Yeah, look at that. Nice.
Yeah. Yeah. And I think this is just, I don't know, I don't know what your all experience is. I feel like we do, sometimes CTs and sometimes MRIs to look for vasculitis. And I honestly feel like I can find it or I see it better on CT than I often do on MRIs. I feel like the MRIs can sometimes be harder to interpret the wall enhancement.
Agreed.
All right, those are my cases.
Rentinogram.
Okay, I'm not sure. This could be a radiograph. It's one of the other. Okay, so this person had lung transplantation at an outside hospital, and a couple of decades ago, there was a lot. Often we would see that there would be these anterior rib cerclage wires, in addition to the transverse, more localized transverse sternotomy wires, approximately. So you'd often have these big butterflies of wire that went out to the sides on both sides to stabilize the whole thing. So this person had that kind of closure here with these wires which have fractured. And if you look carefully, you see that there's a deficit of wire on the left here. Got this big fragment and this fragment. We have a lot more close to intactitude on the right here. We've got, wires that are almost the complete butterfly here. And then we have this sucker out here, which seems to be aberrant. And on a lateral view, we can see that there is a fragment way posteriorly back here. Okay. So, and then here is that fragment of wire here in a pulmonary artery. So this is an embolic fragment.
Wow.
And the hypothesis is that these are the wires up here anteriorly, that one of those left-sided wires, since the left side is the deficient side, you can see the wire going through the sternal cartilage, the rib cartilage here, and it ends up being very close to the right ventricle here. So it would be fairly easy for, like this wire here, to just poke into right ventricle and then from there embolize to the pulmonary artery. So that's the hypothesis of how this got there. So a embolic wire fragment, and I think we are seeing the donor site here because of the deficiency of wire here on the left. So,
that makes sense.
Yeah.
Okay, so
yeah, our surgeons now use plates on all the transplants.
Right. Yeah.
We still have one surgeon who does this occasionally, who does these cerclage wires. But yeah,
Yeah.
I've seen at least one radiograph also where that wire fractured and is like clearly poking into the RV.
Wow, you've seen it actually poke.
Yeah,
You cut it
I think
right.
so. I think they went in and took it out and the patient was fine, but I've seen it where it's like clearly going into the heart.
Sounds
Yeah,
unpleasant.
Yeah.
yeah, we have one that's still lodged in the RV from like a decade ago that
Oh.
it's been stable and they don't want to go back in and do anything with it because it
Mm.
hasn't caused problems. But the patient shows up like once a year for an annual radiograph and there it is. Same theory, it migrated, broke off,
Yeah.
and this one
Yeah.
just got stuck on its way.
So the horror is brought to a new generation of residents every year. That's good. Okay, so continuing with a theme here, this person, Jeff showed some cases last week of these biventricular leadless pacemakers that talk to each other. I think this is called Aviera or something like that. It's got some name like that. And so this person had these things implanted here. And then we got some, let me just show you the course of the radiographs. The things, this ventricular one seems to have changed orientation there. So here it was looking horizontal and now it's vertical. This is the attachment end here, this busy looking end with the more metal pieces. This is the little holder that they use to attach to the catheter or the wire that is inserting this thing. So this is the attachment end, and this is the end that embeds then in ventricle. So this seems to be flopping around quite a bit. And here it is, appearing to be up there. The atrial one is steady. Sometimes I think they actually put these near the sinoatrial node. I saw one of these things that was at the top of it seemed to be where the cava was joining the right atrium. I don't have a CT on this one to know what they did there, but I think they can put these near a sinoatrial node. Okay, so and here it is near the end. So I think they went in and restabilized this thing because I don't think you want it swinging around that much. It might dislodge. Okay, so this seemed to be a bit unstable there. Okay, and here's, by the way, here's a series the of the angiogram or the fluoroscopic studies when they were placing these things. So let me show you. Here's one of them. This is the atrial one already in place. And then we get down here. Let's see, there's one that has 53, I think. This is where I think they were installing the ventricular one. Here's the atrial one floating up there. And the ventricular one's going to be plugged in here. And this is the wire and catheter that is installing the thing. So let's see what ended up at the end. There it is, seems to be in place there. So you can see the orientation at this point is fairly horizontal and it was flipping around later on. Okay, and here's another instance where one of these things was placed. This is the time of surgery, and at this point the sternotomy was left open, and there are lots of sponges in place here. So this person had a lot of difficulties during the surgery. They had to go back in because there were, they put in one mitral valve, and then they found when they repressurized the heart that it became insufficient. So they went back in and put in a different model. Then they had to close atrial septal defects that this person had too. So this person got initially had two of these devices placed. So they did atrial and ventricular in this person. And this person, we see just one at this point down here. And then we also have a problem here with the enteric tube being looped in the hypopharynx and not going down very far. And this can lead to aspiration. So by the way, if you see a tight loop like this that's centered in the neck and it's very tight loop like this, it's not external. That's the first reaction of the most residents to seeing this loop here is that they say, well, that's external. But if it's a tight loop like this with a narrow caliber, that's precisely the dimensions of the hypopharynx there. So this is always internal and it's always looped there, and that can promote aspiration. Okay, so what happened after this? Here we are later on at this point. We still have this thing in place. It could be in the right atrium at this point. And then later, it's clearly lateral to the atrial border, which is here. And so this thing had embolized. Now, I don't know whether this was
Wow.
the atrial one, because the atrial one's gone now. So I think this probably was the atrial one. But they installed an atrial and a ventricular one at the beginning, and I never really clearly saw the ventricular one. I don't think this is it. And I don't see it anywhere else, but I sort of wonder which one this is. But this embolized to the right pulmonary artery. So here we are with a non-contrast CT. At this point, we have a lot of diffuse alveolar damage. And here's our device in the right atrium. So this thing dislodged either from the atrium or from the ventricle and then embolized to the pulmonary artery. So this person had a very difficult surgical course here and is still in the ICU. So, these leadless pacemakers are, I mean, they seem like a really good idea and stuff like that, but, they're not without some difficulties. Okay, so those are my cases.
Those are great.
All right. Yeah, I haven't seen one embolized yet, but it's just a matter
neither
of
have
time.
I. Yeah.
Well, in this person, it could have been because they went back in a number of times.
Yeah.
So they were, they weren't, this person had layers of surgery. And I think some of the surgery was after they'd already implanted the thing. Here it is nicely on the coronal plane. So it may just be that they were in there instrumenting again, and that's what caused these things to launch. Okay.
All
I also
right.
feel like I've asked cardiologists this a couple times and haven't gotten a clear answer, but does anybody know what happens when the battery dies? Like, do they just put a new one in?
They can
Or they
remove
can
them.
remove
So
them? Okay.
I think they have like a 95 or 90% retrieval rate.
Oh, okay.
Yeah, you can take the
That's
same device
great.
to place them and you reconnect it up to it, and you
Cool.
can retract the little tines. But they have like a 9-year battery life or something like
Nice.
that.
Okay.
I don't think they've been around long. But when I
Right,
showed
to
the one
figure that.
of the dual chamber one last week, it's called the Avere or something like that. That on their website they talk about like you can retrieve them and replace
Cool.
them.
Awesome. Thank you.
We just haven't gotten to that time point
Yeah,
yet.
absolutely.
All righty. See, you guys see a CT scan?
Yes.
All right. So this is a 70-something-year-old lady who has this kind of chronic problem, which is actually very rare, but you can see this left pulmonary artery does not look normal. And this is not a chronic PE, but rather a chronic dissection. You can see there's the flap and there's some thrombus associated with it, and it goes all the way down here. It looks like a chronic aortic dissection, right? There's like the two lumens and all that there. And pulmonary dissections are exceedingly rare. First of all, they're lower pressure. Many of them are fatal and often associated with severe pulmonary hypertension. But I had an older study that showed this being exactly the same from many years ago. So I've only seen one other one, and it was not a good outcome. They're, again, very, very rare, but just not to be confused with chronic PE.
Jeff, what was the cause of the pulmonary hypertension?
Unknown. You can see her PA is big, her RV is thick. I think it was just unknown, idiopathic.
Okay, wow.
But she's 70-something years old. She doesn't have any underlying really parenchymal disease. So, all right. So I'm going to be on a little bit of a vascular theme today. This is a cool case. So this is I think this is a 4-year-old who has some really cool anatomy. So you can see, first of all, we've got this funny vessel coming in here. So we've got this left pulmonary vein, superior pulmonary vein, draining into the brachiocephalic. We have a left aortic arch, but we also have this right superior pulmonary vein draining into the superior vena cava / brachiocephalic vein. So both the upper lobes have anomalous venous drainage. So that always makes you wonder what else is going on. And if you come down here, you can see there are the two inferior pulmonary veins, and there is a variant where they kind of come together and then insert into the left atrium. But you see here, they actually insert here into this vertical vein that then connects into the coronary sinus into the right atrium. So this is a total anomalous pulmonary venous return. Of course, there's got to be a shunt somewhere. So there's an ASD right here. It's almost like a sinus venosus type ASD. So this is called a mixed type, where you have these going, the lower ones going into a vertical vein, but the upper ones are draining into the brachiocephalic system. And then, of course, right aortic arch, otherwise normal. Because there's a shunt, there's a dilated right ventricle like that, but there's no aortic anomaly. So this is a total anomalous pulmonary venous return with sort of called the mixed type pattern. Very unusual to see this.
So Jeff, just how much of a vertical vein is there between that confluence of the pulmonary veins and the coronary sinus? It looks as if it's really very close. No, it looks like
Yeah, there's not
looks like
much. They
about an
come
inch
in.
there. What?
Yeah, and just here, and it's really just comes into the coronary sinus. It's not a very long one because it's just the lower veins. But yeah, you can see there's the right vein, the left vein's coming in down here into this vertical vein right here, and this right connects right up into the atrium. And then you can see there's the left superior going up into the brachiocephalic, and then the right superior coming into the cava here.
Wow.
And then there's the sinus venosus. Where was it? It was, yeah, there's the sinus venosus. I show it better on the axial. The sinus venosus ASD is the shunt right here.
That's great.
Got it.
Yeah.
Really interesting.
Okay. And then this was a
4 years old.
Yeah.
Yeah, I think 4 years old. It was, yeah, not a neonate.
So not,
Um,
I mean, not doing that badly then.
yeah, I mean, usually they're cyanotic, right? But
Yeah.
I guess the sinus venosus ASD was big enough. So here's a variant. Now, this was just an incidental finding in an adult, and I don't think I've seen this. So already, one of the rules I have is you're not allowed to have any vertically oriented vessel lateral to the aortic arch. Now, this one runs more horizontal, so you might think this is just a big fat superior intercostal.
Mhm.
But if you notice right here, it actually stops and goes into the lung. But we also have a superior pulmonary vein. So this is just draining the apical posterior segment. And I don't think I've ever seen a partial anomalous pulmonary venous return. I couldn't come up with a better name. So it's PPABVR.
Love it. That's great.
I don't know if you've ever seen this before. It's just kind of a cute finding.
No, I haven't.
Okay.
I like it.
And then this one, unfortunately, I don't have a pre-operative CT, but it still shows what I want to show. So this is a patient that had a big shunt, and there's this vein right here that drains the right lung that now is connected to the IVC coming into the right atrium. I'm sorry, into the coming in here. So this is coming into the left atrium. So there's a vein. So this is a repaired scimitar. We only had a cardiac MRI. But what's cool with her is the other things we see. So we clearly have a hypoplastic right lung. And if we look at the airways, we see there should be an upper lobe bronchus. Here's carina. There should be an upper lobe bronchus, and there isn't. So we follow it down, and there's a single segment coming off this branch. So that looks like trying to be maybe a middle lobe there. And then here we are in the lower lobe, but there's clearly not enough airways. So we have hypoplasia and hyposegmentation of the right lung. It seems to be a single lobe, maybe trying to be a middle, partial, lower lobe combined. Clearly no upper lobe involvement. But what I think was the coolest thing is something we've talked about in this conference is there's a little bit of lung, crossing over here into the left hemithorax. And this is connected to the right lung. And then there's clearly a membrane here. So this is the so-called, quote, horseshoe lung. It's not a true horseshoe lung because they're not fused, but it's passage of a portion of usually the right lung into the left hemithorax. But because there's intact pleura here, it's not a true fused horseshoe lung. And we've seen this in a couple of scimitars. So
Interesting.
yeah, and I don't think there was, let me see, the other thing to look for with these that's fairly common, if I can window it, is systemic arterial supply, but I don't think she did not have that. There's this tiny little vein coming in here, which is kind of curious. But yeah, so what they did is they disconnected the scimitar vein and connected it to the left atrium to close the shunt. So that's typically the repair if the shunt is big enough. And this was just post-op, and that's why there's all the atelectasis and effusions. But other than that, you can see she had a big enough shunt. She developed some pulmonary hypertension, but there's no other cardiac anomaly in this patient.
Nice.
So a little vascular